So it's sort of a philosophical question as to why we should update the guidelines, but I think that in fact that will be obvious. And I think the other thing we're supposed to talk about this morning is the evidence and the gaps. And so I'll be talking about the gaps in the guideline development process. And there we go. So the guidelines just came out in 2014, so you could well ask, why update them? I haven't even finished reading those. You're going to already make them new. Well, a very quick PubMed search, not with any filters or anything, will show us that there are, thousands of new publications on heart valve disease since 2014. A large number of systematic reviews or meta-analyses and a large number of randomized clinical trials. No doubt this is an overestimate because I just did a rough look at the data, but there is clearly a lot of new published data. We have new analysis of cumulative data, but we also have better imaging and we have better interventions every year. So guidelines need to be updated. And so I would like to thank Rick, my co-chair, and all of the people who contributed to this. Is a very intensive process to update these guidelines and present them to you today. So in the new guidelines, with all ACC guidelines, you'll now see we still have our levels of evidence of Class 1 strong, and then 2A and 2B, which are more moderate and weaker recommendations, and then Class 3 divided into harm or just no benefit. But we also have under quality of evidence, the levels B will be now divided into randomized and non-randomized as well, so you'll see those in the guidelines. But one of the challenges or gaps in guidelines is there are so many guidelines and there are so many new papers, and it takes a lot of volunteers and a lot of time to do these updates. A focused update takes over a year, and a full update takes longer than 2 years. So it's very slow compared to the rapid progress in medical research. So I would like to talk about some alternative approaches we could consider adding to the ACC-AHA guidelines to make them more of a dynamic, rapidly updated guideline. And this is an example of a project I worked with called the MAGIC Project, which is a platform designed to develop trustworthy and timely guidelines, which you can see their website here. But here's the problem we face when we update guidelines from any organization, is we have a patient with a clinical problem. He has severe aortic stenosis. He has read about TAVR or TAVI and wants to know, can he have this new procedure? And we have new evidence now. Almost a year ago, the PARTNER 2A trial of intermediate risk aortic valve replacement with transcatheter valves. And as a clinician, we face a lot of challenges. There's more than one study. There's several studies. So how do we combine the data from those studies? Should we consider observational data, or do only randomized controlled trials count? What's missing? Do these apply to this patient in front of me now? And is that data that's been published strong enough to change clinical practice? And of course, we can add to these 3 studies the SIR-TAVI trial presented yesterday as well. So when we think about guidelines, we try to think about what we call a PICO framing of the clinical question. That is, who is the population we're interested in addressing? In this case, severe symptomatic aortic stenosis with an intermediate risk for surgical valve replacement. And we also thought that within this group, age is an important consideration in which choice you might make. What is the intervention? And transcatheter and valve replacement is not all the same. Transfemoral and transapical have different risks and different outcomes. The comparator is surgical AVR, so we need to look at the data from that, and we need to define our outcomes. And so our group defined 14 important outcomes, the most important being stroke, survival, bleeding, and so on, as well as valve durability and reintervention. So you start with a group of content experts, which is the way we do it at the ACC-AHA, from multidisciplines across the spectrum of cardiovascular disease. But what the Rapid Recs process or MAGIC process does is to also include a separate independent group of research methodology experts. And the content experts say, here's our PICO question, here's what we want to know, here's the 14 outcomes we want data on, and here's how we want them stratified. The research methodology experts look at that data, they provide a meta-analysis, systematic review, they grade the strength and quality of the data, point out missing data, and bring that back to the content experts in an iterative process. The other part of this process is the patients, and we should be involving patients from the start in terms of their preferences and values, practical decisions, and actively be involved in decision making. So for example, with this process, here's an example of the kinds of combined data we were shown, the survival curves for surgical versus transcatheter valve, which are very similar, possibly slightly favoring transcatheter, and the traditional forest plot showing both transapical, which favors surgical, and transfemoral, which slightly favors transcatheter valve replacement. But beyond that, we were also provided with these kind of detailed tables for each of the risk stratified age groups, showing here the population of patients over age 85, comparing transfemoral valve replacement to surgical valve replacement, and then a graph for each of the outcomes, the actual study results and measurements, and then absolute effect estimates for surgical versus transfemoral, the grading the quality of the evidence, and a summary. And this kind of data was shown for each of the 14 outcomes that we had defined for each of the 4 age groups. And notice that we did include patient-defined variables that were of importance, such as quality of life, length of hospitalization, pain, and recovery time, things that are more difficult to consider in some other processes. So this process involves framing your question, looking at the evidence, grading the evidence, and coming back to the panel of clinical experts from across the spectrum of cardiovascular disease who then make recommendations about the procedure. So in this case, the recommendations are then presented in this type of format for transfemoral versus surgical, with a strong recommendation over age 85 for transfemoral TAVI, and a strong recommendation under age 65 to continue with surgical valve replacement. These kind of displays are multi-layered. That is, you can click on them and go to more and more detailed data, and they have multiple ways of display. So if you click on Y under the age 85, you then come to a screen like this, showing us the actual numerical data for that particular subset of over age 85, shown in a graphical display with color. If we look at the under age 65, a similar display showing the arrows going predominantly in the other direction towards surgical valve. So we do have uncertainties, and those are defined at the bottom here. In this case, the major uncertainty being durability of valves. It's wonderful that they're durable for 3 years or so, but it would be nice to know that they're durable for over 10 years. So if we compare that to how does that fit in with the ACC guidelines, they work together very nicely. In our new guidelines, we'll be hearing that for intermediate risk surgical patients, we recommend TAVR with a Class 2A indication. And what platforms such as the Rapid Recs can do is to take this and then subdivide that category even further. So if we just focus here, the low to intermediate risk patient, it takes that same group and spreads it out by age group to define a little bit more detail how we might manage our patients. The other challenge we face is the need for communication experts. We need to be able to look at our guidelines in multi-layered decision aids that are user-friendly and that are there when you need them. You know, we do have smartphone devices, but how many apps can you put on your phone and find the one you need when you need it? You know, we need to have these guidelines updated frequently, like continuously almost, and it's very difficult to do that with our current process. We need them where we can see them in the electronic medical record, as well as adapting them at national and local levels. And we need what we call decision aids for patients and clinicians, ways to show the patients the data, to see it ourselves when we need it. So the ACC-AHA guidelines, as well as ESC guidelines, are very important. They've positively impacted the care and outcome of patients with cardiovascular disease over the past 30 years. They summarize complex issues, they provide us a framework, it's evidence-based, they identify knowledge gaps, and they guide clinical management as well as informing healthcare policy. So let's keep them that way. And in order to keep them that way, the challenges we face are we need to partner with other platforms or develop our own to have digitally structured data that can be dynamically updated and published, as well as providing consultation decision aids with rapid responses. We need research methodology experts involved from the beginning, providing rigorous review of the evidence with no bias. We need communication experts to disseminate the information and integrate it into the electronic medical record. And we need to involve patients in shared decision-making, as well as from a societal point of view, considering the resources involved in the recommendations we make. We need guidelines that are trustworthy, transparent, timely, and there when you need them. Thank you for your attention.